going to talk about the management of AVMs. We all know about AVMs. They're one of those very challenging conditions, depending on how they present or sometimes even treatment. So here's to hoping that Jeneral sheds some light for all of us. Thank you. You can go ahead.
Can I be heard?
Yes, sir.
Thank you, sir, for the kind introduction, and my sincere apologies for the hitches that we have. I'll just go straight to the topic. So we're looking at management of arteriovenous malformation. Truth is not a new topic to most of us as neurosurgeons. Just to put some light to some areas as it pertains to the WASI fellowship program that we're running. So I will use this outline. Can we next slide, please? So just to put a definition to what arteriovenous malformation is. Next slide. I think it's, as we all know, it's just a direct communication between the arteries and the veins without an intervening capillary bed. Yeah, the word congenital is commonly used most often, uh, but it's something that is becoming debatable across many climes. But what's characterized of this connection is the fact that you have these plastic maldeveloped vessels that are characterized with high pressure flow. It's one of the common intracranial pathologies that most neurosurgeons will face, accounts for about 4 to 60%. Next slide, please. So this kind of shows what it is because the normal anatomy of vascular connection is from arteries through capillaries and then to vein. But in AVMs, you now have direct shunting of arterial blood connecting with the venous circulation. Next slide, without an intervening capillary bed. McCormick kind of define or describe vascular malformations, four categorical types of vascular malformations, of which AVM is one. Other vascular malformations are anomaly of venous drainage, which could be the one commonly seen is the developmental venous anomaly. Capillary telangiectasia can also be seen. Cavernous malformations, another kind of vascular malformations. But our emphasis is not on this, but these are other vascular malformations, especially the central nervous system that can be encountered. Next slide, please. As a way, next slide, please. As a way of trying to, give us some relevance to why we're looking at this, it's a rare disease, accounting for about 0.2 to 0.8% of vascular malformation, of intracranial pathologies generally. And the AVMs actually is a distinct group of disease. And for years, it's something that, just as Dr. Alalade said in the beginning, that is something that we encounter that's terrified and fascinated neurosurgeons for decades. As a matter of fact, Christians once said that it is actually foolish to attack this kind of disease, more also that is associated with a lot of serious cortical complication, and that only if only the imaginations of the mind can help us try to figure out complications that have not been documented. Next slide, please. So like aneurysm, it can easily rupture with serious consequences, but unlike aneurysm, it is not de novo, it can be silent for years. But like brain tumors, it can be found on any part of the brain with a lot of deficit. And like developmental anomalies, its onsets variable, and sometimes it can be difficult to really put a class to it. But most fascinating about AVM is the fact that they are unpredictable, and these lesions sometimes can't have a very difficult and predicting, natural history. Understanding it actually in trying to study the natural history has helped a lot of understanding about the embryology of cerebral of the brain vessels. Currently, the approach to treatment is multidisciplinary, and this approach consists of microsurgery, radiosurgery, and endovascular. And it has actually moved fast or advanced faster than even the knowledge of the disease itself. We've gained a lot of knowledge from the Rubal trial with respect to the rationale of how this disease should be treated. But however, um, the endovascular treatment of this disease has been shown to be one of, because both diagnostic and interventional aspect can be done through endovascular means. And it's been shown that a lot of problem happens, particularly during the procedure, especially when getting the catheter out. Also, even after the procedure, you could also have some complication, especially that has to do with the perfusion injury. I won't bother us with this because we've talked about this previously. Uh, Next slide, please. So there's a lot of history to it, but McCormick was one of the person who gave kind of this classification of the vessel. AVM actually is ill-defined in the sense that the incidents actually, it's been difficult over the years. A lot of study has been done. Most of the knowledge gotten is from autopsy, but generally estimated that in the general population it's about up to 0.8%. The estimated people in the US known to harbor this is about 300,000, and that is about 200 to 500 people lives with this disease. The study that has actually given us a lot of understanding of the epidemiology is the New York Island study that shows that the detection rate is about 1.34 per 100,000 persons years. Also, a study from Minnesota also revealed that it is within 1.1 per 100,000 persons years. It's actually a disease that's commonly seen in the third and fourth decades of life. About 64% are diagnosed before 40 years. In some studies, you find out that it's equal in both male and female, but it could sometimes be up to 2 to 1%. Majority of it are supratentorial, and less common site are brainstem and deep location like the ventricle. It's also rare in children, but there are variants that can also be seen commonly in them as we see further. They're typically solitary in most cases, but in up to 9%, you can see them multiple, and usually in syndromic cases, like in Osler-Weber syndrome or hereditary hemorrhagic telangiectasia. Next slide. So older patients may be more likely to have hemorrhage and focal deficit from the disease. But it's been shown that 2% of stroke and 38% of ICH develop in younger age group of patients. A study have shown that you could have regression, particularly in small AVM, up to 2 to 3%. Classification of AVMs actually can be looked at in several ways. You can look at it from the anatomy of the disease itself. So looking at that, an AVM classically will have a plexiform type, which is the one that we commonly see, where you have an artery going through a nidus and then to a vein. That is the common one that's commonly seen in adults, but the fistulous one also could occur, especially in children, where you just have a single fistulous connection between the artery to a vein. Sometimes you could have both. Next slide. Okay, sorry, can you go back? So if you look at this, sorry, go back, a slide back. No, you're going forward, please. Okay, yeah, if you look at this, you will see that in the angiogram that is shown here, you will see especially the lateral view. You could see a kind of a connection here between a vein, between the posterior and inferior cerebral artery cortical branches, connecting with a draining vein that opacified the transverse sinus. So this is like a single track without a nidus. Next slide. Unlike what you see in the next slide, where you have a classical arterial supply from the middle cerebral artery to a nidus and then draining through a cortical vein into the superior sagittal sinus. Next slide, please. Yeah, this is also showing a single fistulous connection between an artery and a vein. Next slide. So basically, our discussion was centered more on the pial or parenchymal AVMs, but other AVMs can also be seen, particularly the galenic AVM, the cavernous fistula, which we discussed last week, where you have connection between the internal carotid and the cavernous sinus. But our emphasis will be largely on the pial AVM, or which is the parenchymal AVM. Lawton kind of put a classification to it based on location in the brain. You have the frontal, the temporal, parietal. Can we go to next? So these are the subclasses under them. Next slide, please. You have the deep ones, which are purely in the sylvian or basal ganglia. And then you could also have the posterior fossa, which could either be on the brainstem or it could be on the cerebellum. And we'll see that in the subclass there. The etiology of AVMs actually is not clearly known, but there are two popular theories that kind of try to explain the congenital and the vascular abnormality theory. The congenital kind of implicate a developmental problem that starts with failure of stable vascular and capillary plexus during the period of development. And this failure could either be sporadic or it could be syndromic. As I said, a lot of syndromes that associated with this. But the question is, a lot of incidental AVM are not seen in children. And so fistula is what is commonly seen in children, but this is rare in adults. So it's that maybe there's, congenital process, and then you have these fistula connections, and then with this fistula connection that tends to grow over time and becomes, the exiform type. And these are questions that are yet to be answered. But one of the things that is common is the presence of a venous abnormality. And that is what has supported the venous abnormality theory, which was seen in cases presented in the early 70s, where you have venous thrombosis, either the sinus or hypertension, and the fact that a lot of patients who have this AVM. So venous anomaly has been shown to actually play a significant role in the development of this AVM, their recanalization, as well as their growth. Next slide. The molecular concept about it is the fact that when AVMs are partially embolized, or when you have complete when AVM are partially, can you go back? When AVMs are partially embolized, or sometimes when you have a complete ablation of these AVMs, you find out that you can have either reestablishment or regrowth. Sorry, can you go forward? So these AVMs have been shown to either regrow, or you can have some kind of recurrence of AVM. So that has led to the, research finding why does this happen, and a lot of genes have been implicated in that respect. Over 100 genes shown to be altered and these genes involve largely the process of angiogenesis, and they play a role in normal physiology of brain and immunosurveillance. So these are the factors, angiogenic factors that have been implicated: virgin hypoxia-induced factor alpha, and a lot of them. Some other factors, again, that have been implicated is the fact that these cytokines or angiogenic factors have been shown to also increase or been implicated in angiogenesis of fibril collateral pathways in moyamoya disease. And also even in syndromic conditions where we've mentioned earlier, you find out that these markers are quite, increased. For partially thrombosed AVM, those that have maybe embolization before surgery, maybe partial embolization before surgery to reduce blood flow, this factor, especially vascular endothelial growth factor and hypoxia-induced factor alpha, has also been shown to increase in those groups. So these are all factors implicating the fact that genetics plays a role in both the development and growth of and reestablishment of AVM. The principle that have been implicated for this, the fact that hypoxia and alteration of flow kinetics can actually result in upgrading of mRNA production, which now upgrade the production of these growth factors or angiogenic factors. Well, next slide. These are just some syndromes that have been implicated. Next slide, please. Next slide. Yeah. So the basis is the fact that it's either you have AVM developing from vascular abnormality, or you have genetic alteration that is responsible for their development. Next slide. Now, this is a kind of trying to explain how this happened, that when you have this vascular event, especially in the presence of hypoxia or venous hypertension, you have the hypoxia-induced factor alpha, which is released and stimulate the production of VEG. VEG now stimulate focal angiogenesis through the recruitment of leukocyte macrophages and all those other processes. Next slide. Yeah, so once that's happened and you now have AVM developed, what is common or what is classical in AVMs, especially the classical AVM, not the fistulous type, the fact that you have this plastic vascular nidus, which you may have single connection between an artery and a vein, or you may have multiple network of connection of blood shunting through. These feeders could be small or could be large, or you could have a large single arterial feeder with other smaller feeders. And then you have draining veins. Draining veins could be single or it could be multiple. But what's also obvious, the fact that you have absence of capillary bed. Next slide. Now, once that happens, it allows for a kind of low resistance because of the absence of capillaries and low resistant vessel across the bed. And once you get that, you have a lot of blood shunting on a high volume of blood shunting through this low resistance pathway and is draining through the veins. And once that happens for a long period of time, a lot of changes begin to happen in the arterial feeders. They become dilated and fibromuscular cushions develops in them. The venous system become materialized because of the high pressure, high flow, direct connection from the artery. You could also have aneurysms that may develop, because of these hemodynamic changes. And this aneurysm could be within the nidus, which is usually considered as a flow-related aneurysm, or it could actually happen remote in the case of flow-related aneurysm. This can be seen 50%. Sometimes you could have even the arterial feeders, and 85% of aneurysm actually it's from the arterial feeders. And these aneurysms are believed to develop due to those high flow vasculopathy. Next slide, please. Now, intracranial hemorrhage is one of the things that is seen as a common presentation. Actually, it accounts for about 40 to 50% in some series for presentation of AVMs. And this is because you may have rupture occurring either from the nidus itself because of the dysplastic vessels, or from the vein, or from even the arterial feeder, especially when you have aneurysm arising from them. You could also have this bleeding happening in aneurysm that may be located remote even to the location. So even remote aneurysm can also rupture and give bleed, not just around the AVM. So all this is influenced by the fact that the hemodynamic changes within the AVMs. Now, factors that influence the hemodynamic the hemodynamic flow in the AVM are the flow rate changes, the volume changes, the vascular caliber changes, and the vascular bed resistance is actually one of the factors that have been shown to influence other presentations aside hemorrhage, because you have underperfusion, because you have underperfusion of adjacent brain area, because a lot of blood is shunted through the AVM, resulting in what is called the Still syndrome. That could cause some neuropsychological dysfunction, and that results in autoregulatory changes or loss of autoregulation. And with reperfusion after treatment with endovascular surgery, that can result in what is called the normal perfusion pressure breakthrough, which we talk as the complication. Next slide, of intervascular intervention. So natural history, AVMs are largely have a long course and sometimes can be clinically silent. As I said, a lot of the knowledge we have is from autopsy, also autopsy cases. So it could be asymptomatic for greater number of time, but for the symptomatic ones, for the symptomatic lesion, it's important to understand that though they are asymptomatic for a large part, they can be symptomatic. And knowledge of the natural history, it's important because it helps us determine the choice of treatment and also whether to treat or not to treat, who to treat and who not to treat, and also understanding the perioperative morbidity and mortality that is associated with treatment help us make those appropriate choices. Next slide, please. So for the natural history, it's been shown that hemorrhage, 40%, seizure can also occur. Now, the yearly risk of hemorrhage in the first year after hemorrhage is about 6 to 7%. Now, this has been shown to be very high in the first year, but tend to decline over the years in AVMs. And after 5 years, it's been shown that the risk of hemorrhage decline greatly. But the challenge is, what is the risk of hemorrhage before the first one? There are some studies, particularly from Finland, that have tried to help us understand. The next slide, please. Now, these studies from Finland kind of help us to look at the risks of hemorrhage on ruptured or AVM. So please, next slide. Previous slide, please. Yeah, so about 160 patients were followed up and finished for 23.7 years. That's one of the early presentation that was done in the 90s. And it shows that for those unruptured or untreated and new AVM, about 2 to 4% of them will bleed per year. And the combined rate of morbidity and mortality from untreated AVMs could be up to 2.7% within a mean time of 7.7 years. But this study, which was published in 2008, shows that the long-term excess mortality in AVM versus the general population, at 1 year, shows that high excess mortality rate is seen when there's no treatment. And then you have a comparatively lower excess mortality rate in those partially treated, and that you have no excess mortality among those who were completely treated. So this study kind of favors, even for patients who kind of don't have symptoms, have sizable AVM, treatment can also help in reducing mortality. Next slide. But the Aruba study kind of shows that for, patients who have medical versus intervention in an unruptured brain AVM, about 10.1% of them in the medical group develop complications such as stroke or death, compared to 30.7% in those who were treated. So all of this gives a kind of, next slide, gives a kind of a conflicting information concerning the natural history. And that's why a lot of people believe that it is unpredictable. And the reason is that a lot of factors are involved here. When you look at AVM and its natural history, you can look at the size, you can look at locations, some are deep, some are structured. So most of this factor and the heterogeneity of the group of patients actually are things that made people find it very difficult to predict what exactly the outcome could be. And extrapolating this into patients that, in the future is quite challenging. Next slide. Some have shown some regression. Some have shown that some AVM regress, especially small AVM. But the problem with small AVM is that they have high risks of bleeding. So the fact that small AVM bleeds she will observe them. But again, it's been shown that they have high risks of bleeding. Some have shown that it's the larger ones that bleed. Some shows that, okay, it's because of, increase mean arterial pressure within the feeding pedicle of vessel in small AVM that makes them bleed as against the size. So all these are areas that are still not clear concerning the natural history of AVM. And the most important thing for us to note is that even though we are not sure, but the treatment of AVM2 has been shown to be associated with some significant complication. And the food for thought concerning this is when we have an AVM, the decision to treat or not to treat should be carefully based, looking at benefit versus the risks of treatment, because even the treatment is not completely risk-free. Next slide, please. So I won't bother us about the clinical presentation. Next slide. So these are just how patients can present. Hemorrhage is the commonest, is the most common presentation. Then we now have seizures, then we have headaches. All these are common presentations that we can see. Let's go neurologic deficit. So diagnosis is very, very important for patients. CT angiography, MR angiography, commonplace most of the time for patients who present with bleeding or seizures or persistent headache. CT scan or MR are the first point of call for us, and but definitive diagnosis in terms of uh, looking at the entire picture of the AVM can be better delineated with either CT angiography or MR angiography, but gold standard is a diagnostic angiography, which help you also intervene. So what are we looking for when we're doing angiography? We have to look at the nidus, where is it located, what is the shape. We have to also be sure of the vessels, the arterial field, especially for interventional neurosurgeons, the arteries that feed them, the veins that drain them, and the direction of drain. All these are very, very important in planning treatment. Next slide. This is just a CT scan showing an hemorrhage, and then a CT angiography, likewise an MRI showing an hemorrhage with showing an AVM involving the frontal, the other one involving the interhemispheric area. Next slide. Yeah, so sometimes functional MRI can be quite helpful, especially if the AVM is located around eloquent areas, to be able to determine, because sometimes this eloquent area has been shown to either shift or to have kind of migrated to adjacent brain tissue because of the dysplastic or ischemic, chronic ischemic changes that has happened from the AVM. Next slide, please. Yeah, so diagnostic angiography, as I say, is the key gold standard. It's one of helps you with both diagnosis and intervention. So you can see from the upper two DSA view, this is a lateral vertebral artery injection showing an AVM. You can appreciate the feeding artery seems to be coming from the superior, from the posterior cerebral artery. Yeah, from the posterior cerebral artery. And then in the images below, you could see an AVM involving the left frontal lobe supply from the anterior cerebral artery, and then the other one showing again another AVM that is supplied by the middle cerebral artery. And you could see that in the last image, you could see that there is an AVM located somewhere around the sylvian with drainage through the basal vein with early opacification of the straight sinus, you know. Next slide. So after making after imaging, the next important thing is to be able to grade the AVM. One of the most popular grading system that is used is the Spencer-Martin's grading. Next slide, please. The Spencer-Martin grading looks at the size, the venous drainage, and the eloquence. Are currently back, please. In BNI, one of the things I noticed they always we use the supplemental grading also alongside the Spencer-Martin grading, and usually the supplemental grading adds the idea of age, the bleeding, and then the compactness. But this grading, Spencer-Martin's and the Lawton and Young grading system, is basically to determine the resectability of the AVM using microsurgical approach. But it's what is largely used, especially to also determine which patients will benefit from microsurgery, endovascular, as well as radiotherapy. Next slide, please. So when you have AVM grade of about 6, that is the S&M plus the supplementary Lawton and Young, once a grade is greater than 6, from my experience with them, 7, 8, 9, patients are sent to either have radiosurgery and then subsequently microsurgery. Some of the patients, again, may undergo endovascular, may be sent to the endovascular team for embolization. That's aside the fact that some of them may require multimodal approach to the treatment. So in treatment, generally, you usually will have more. There are some that will require conservative treatment. As I said, because of the natural history and the complication of treatment, sometimes for incidental AVM that may be located, especially in areas where surgical intervention may cause more risks than monitoring or just observing the patient. This patient may just be monitored and watched without intervention. Microsurgery is an option. Endovascular treatment is also an option. Radiotherapy is an option. But the current concept is, even for those going for surgery, endovascular embolization to either reduce flow in some of the feeders. Like in BNI, what they do is when you have deep feeders and you have superficial feeders, the deep feeders are usually embolized a day or two prior to surgery, and then the superficial feeders are taken care of during microsurgical resection. Next slide. I won't bother us with this. Most of us are sure these are the different modalities and that. So conservative treatment, these are the indications. And what do? You monitor the patient. If the patient has seizure, control seizure, analgesics for headache, and then serial follow-up for neurologic assessment, as well as imaging. Next slide. Surgical, I won't bother us about surgical treatment, but usually like in Barrow, and Spencer-Martin's 1 and 2, and then the supplementary grade, once it's not greater than 3, that is when they intervene. Once it's greater than 3 and gives a score of 7, most of the time, patients. So radiosurgery is another treatment option. I won't bother us about that. So next slide. So next slide, endovascular treatment, which is one of the things that for most of us that are here, are the things that we're trying to learn and see how that is done. So embolization or endovascular treatment or embolotherapy is something that can be done. It's done most of the time in conjunction with surgery, and in some cases, it's done alone. It's been shown that it's not a good option for as a single, treatment option for AVM, but it can be done with some degree of complete cure rate. It can be done in small AVMs up to 80%. For very large AVMs, it doesn't completely eradicate. In just few cases, up to 40%, you can have that, but it also have risks. Next slide. So we want to look at the next slide, please. The embolic agents. Back. Can you go back? The embolic agents that commonly can be used for endovascular treatment. The NBCA, which is N-butyl cyanoacrylate is one of the embolic agent that has been used, also called true film glue. Some call it glue. So it's extremely effective as an agent. You know, it reduces the inadvertent. It's been very effective as an agent. You know, but the problem is that you can have embolization into normal tissue. So it comes as a preparation of Trufil in 1 ml of metal tube, is usually sealed, and comes um, with a solution, a thiodol, which is used in comes in a mini vial that is used to dilute and make it and opacify it also during angiography. Also have an adapter that can be used to perforate the seal with this one syringe, 1 ml syringe. You can also use an 18 gauge needle to be able to aspirate. The mixture is usually done in a glass mixing jar in a separate place. The whole idea is to prevent contamination, and especially with saline or with contrast, because again, it's been shown to polymerize easily, especially when it is placed in an ionic, when it mixed with ionic solution. So it's important that when preparing the solution, you will get a new gloves, and then the catheter, that is the micro catheter, it's important that the micro catheter be flushed thoroughly with dextrose ahead of its use. Next slide. And it's also advised that you get somebody who is experienced to be able to monitor the process during the preparation. The preparation is key because early polymerization can happen. Now, how does it work? It actually can, it NBCA, you know, in an ionic solution of alkaline pH easily solidifies and is an exothermic reaction. So that can happen anywhere from preparation along delivery, and that's why the preparation and delivery is carefully done to prevent polymerization while you try to deliver it through the catheter. It's very, very important to use bolus 5% dextrose or glacial acetic acid to kind of flush the catheter. And it's also important that for the person doing the angiography to determine the angiographic point as at which the glue solidifies. And that can be done depending on where the glue. So if you want it delivered more distal, you kind of add more of the thiodol in the mixture. So several concentrations can be done. You can be up to 100% preparation, especially if you're trying to do a kind of a direct fistula embolization. When you have a direct fistula, you're trying to embolize it. But commonly, the preparations that are usually used are within 25 to 30%. Next slide. Another point when using NBCA is the fact that you have to anticipate the catheter removal. It's very, very prior to the catheter removal. That point needs to be really anticipated by both the operator and the assistant. The reason is because sometimes the pulling of the micro catheter, if not done at the appropriate time, that can result in the catheter tip either being stuck to the glue, and then in the process, it can also result in a lot of complications. As a matter of fact, it's said that most complications occur at this point. And that is why it's important to loosen the valve to allow for easy passage, anticipate the time and place where that will be done. And then the whole catheter, some try to avoid that by pulling the whole catheter simultaneously to avoid a kind, because when you remove the micro catheter and the catheter together, kind of avoid, you know, shaving of pieces of glue that may eventually embolize subsequently. The other embolic material which is commonly now used in the US, this is one of the most popular agent that is being used. It was introduced in the market in 2005. It helps solve the problem of NBCA, and it comes as a copolymer with dimethyl sulfur oxide. and it detaches from the embolus after injection, and then it precipitates to form the soft gel now precipitate to take the shape of the vessel. This is the preparations, the bottles, and how it comes. Next slide. So it has three forms: Onyx 18, 34, and the HD 500. These are the different composition. You know, as I say, it comes as a copolymer with the dimethyl sulfur oxide. So the preparation of it, it's important that it is agitated or shaken or agitated very well. And the problem with it is that you have to use compactable material like the catheters. You have to be sure that the catheters are compatible with the use of DMSO, and also the syringe also that you will need to use to draw it also must be compatible with your catheter. And the catheter should be primed with, you know, the catheter in NBCA, it's primed with 5% dextrose. Here, you prime it with liquid DMSO. And it's important to also know the volume, because you need to know the volume because you're priming, and this volume of DMSO within the catheter you are using tends to deliver first when you're delivering your onyx, and it deliver at the rate of 0.5 mils over 1.5 minutes. So it's very, very important to know the volume so that you know how much to deliver. And also it's been shown that there's this problem of halitosis or bad odor with it. So counsel the patient ahead of time, because within the period of few days after, patient may have some bad breath. So family needs to know, patient needs to know. How is it injected? The goal of the injection is to be able to penetrate the nidus and reduce the risk of injury to adjacent tissue. So there are several techniques that are used to be able to achieve that. So you can use a parallel catheter. Please, you can use a parallel microcatheter technique. Well, like at this stage, to be sincere, Okafo, I will be sincere with you. This technique kind of a thing, I'm just reading what I saw. Because I don't have experience with this. So they talked about the parallel microcatheter technique. I don't really understand that. But that what is done is that you put like, is it like 2 catheters or so, and then one delivered Onyx 34 distally, and then you now use the other catheter to deliver Onyx 18 beyond the proximal, the Onyx 34 proximal, and then you put Onyx 18 in the other catheter and deliver it distally. This is a kind of to prevent the Onyx from embolizing or from you know, going into the vessel and to other areas of the brain. I'm not sure. The other technique that said can be used is when you use a single microcatheter technique, where you switch that you use Onyx 34 for proximal block, then you now use 18, you know, subsequently, you know, to plug the AVM. I'm not sure how this works. Maybe you explain better, we will be able to get to grab that. Then there's a double catheter technique. And then also some said you can use adjunct balloon to plug feeding arteries, or transvenously you block the veins, then you can push your onyx. When that is done, in most cases, you'll be able to achieve, you know, total angiographic cure, especially in the for the AVM. But high rates of total occlusion is also possible when you do that over a long time. But when you do that over a long time, the possibility of complication also happen. And that most complications happen, as I've said, during the removal of the catheter at the end of injection. Next slide. So next slide. The other agents that have been used, well, not gaining popularity. No, next slide. The other agent that have been used, not gaining popularity, is the dehydrated alcohol. The mechanism is that it causes a kind of an intimal injury and induced thrombosis around the catheter tip, and that happens within 5 to 10 minutes, and that kind of block the vessel. The thrombosis kind of block the vessel. Another thing with it is that it doesn't tend to embolize as commonly as onyx and as NBCA, because that as it goes through the entire nidus of the AVM, it tends to dilute. So it's not associated with that. And that for this is simple and easy, and just that you have to rehearse how to inject it with contrast before you use it. The problem is that it can cause parenchyma because of alcohol, can cause toxicity in the brain. And sometimes you could even have catastrophic pulmonary, hypertension from embolization of. So it's usually advised that you limit, the volume that you use, about 1 ml per kg of body weight. Next slide. These are other embolic agents. Coil are easy to use, but they're very, very ineffective. They do not tend to penetrate the nidus. They tend to deploy early and don't tend to penetrate the distal part of the AVM and the nidus, but they can be used as agent for pre-surgical embolization, and they can be actually safe. You can actually use them to partially embolize a vessel, and then the patient can go in for surgery. You can use it to slow flow in a vessel and subsequently use an embolic agent alongside with it. It's shown to also be safe. Polyvinyl alcohol is another agent that is being tried but fall out of use because it's ineffective, and even when it is used, its effect is often transient. Within a week, you have recanalization, and the other agents are the thread and the gel form, which also have fallen out. So commonly, the two agents that are commonly used are the MBCA and the onyx, but onyx is the most popular agent that is used. Next slide, please. So for endovascular embolization, it is without complication. As I said, you could have, as a matter of fact, tear and perforation, and sometimes you could have even the embolus of the embolic material without you really, if you are not really paying attention. That can cause a lot of showers of this material in the brain and with subsequent damage. So excessive and early venous penetration can also be a problem. It's advised that when that happens, you can actually move the patient to ICU and plan for early surgical intervention. Intraprocedural tear, sometimes the vigorous movement of the catheter in and through the nidus, because the vessels are quite dysplastic. And then sometimes even for the aneurysms that may be either be within the nidus or feeding arteries may rupture during the procedure. So that is also a complication that one needs to know. Then you could have reflux of embolic material into normal proximal vessel. That is one feared complication that it's saying, and it's important that during the process of retrieval of a catheter, attention is paid to that to prevent that. As a matter of fact, it's that one needs to be sure the safe position where to put your micro catheter before you deploy your embolic material, because if you're not at the safe location, by the time you're trying to come out, you could just have a reflux, and that could just occlude the entire vessel and give the patient either a stroke. So back thrombosis is a phenomenon that have also been seen to happen. Some say because of the stagnant or flow that has happened in the vessel. Some said because you could also have retrograde thrombosis from the embolized vessel. I'm not sure how that happened, but it's been said to be one of the complications. And then the normal perfusion breakthrough that can bleeding that can happen after successful occlusion. That's why from my introduction I said it's not about the treatment, but also the post-operative follow-up and management of the patient is very, very key, because these complications can happen. Well, I won't bother us about this advantage, and we all know the advantages and disadvantages of use of endovascular intervention. In conclusion, I will say that AVM are very, just like Alala said, they're challenging to everybody. I know, being at BN, I have seen Lawton, seen aneurysm. He does a lot, but I've seen him also feared some AVMs. He'll tell you, this one I will not touch. So there are quite important. That's why all the knowledge, individualizing patient is very, very key. Knowing which patients will benefit from what is very, very important. And if treating patients that are asymptomatic, we have to be careful selecting those who we think that will benefit as against, the risks of complication. So all these options exist: microsurgery, gamma knife, endovascular treatment for treatment of AVM. But medium-sized AVM actually, for most cases, require both multimodal approach, microsurgery and endovascular commonly. Thank you for listening, and sorry for the hassles I had.
I think that was a super presentation. You managed to cover so much within the time allotted, and I'm sure everybody learned one or two things. And of course, you've recently been at Barrow, the home of AVM. So who else to give this presentation? I think I'll leave the floor open to questions. I've got so many comments to raise about a few things because you covered too many. I'm just wondering how I'm going to fit them in. But hopefully questions will come up and then we'll be able to tackle them because I'm wary of the time as well. I don't want us to stay too long. Any questions from anybody? Okay. If you have questions, just put up your. Oh, Uche has a question. Okay, fine. Yeah.
I just wanted to commend Jeneral for an excellent presentation. You did a great job, man. Listening to you did a very fantastic job. So my question, maybe I'll just throw it open. Let's just quickly talk about the endovascular. Would you counsel a patient who has an AVM for endovascular treatment for cure?
Okay. Should I respond, sir?
Yeah.
Okay.
Yeah. Go on. Are you talking to me
Yes.
or I know what my answer is. Yeah, General.
General, you're on the hot
Ahead.
seat. Give us answer.
So I was keeping quiet, thinking you will step in, sir. But
Save
let me
you.
give.
Oh.
let me just say my little thought about it. Yes, there are AVMs. Yes, there are AVMs that could actually benefit from endovascular treatment, but as in curative treatment, you can obliterate using endovascular approach. There are AVMs, but as I said, let me borrow a lead from my experience. One of the things I noticed that is you have to select your patients carefully. That's one of the things I noticed that you have to be sure that, okay, which group of patients will benefit from this approach. Like, for example, a medium, small AVMs, or when you have AVMs that you have the fistulous type where you have an artery, directly connecting to a vein, or small size AVM with single feeders, AVM with single arterial feeders, or venous drainage. Those ones you can successfully cure them endovascularly. But when you have AVM with multiple feeders, that can be difficult. Very large AVM, that can quite be difficult because most of the time, from what I noticed, they have a lot of feeding vessels. Some of these vessels may not even be accessible to the catheter themselves. So that may cause challenging, may be a serious challenge in trying to cure them endovascularly. But I think there are patients that one can select. And then there are patients that may not be candidate for surgery, either because of comorbidities or maybe because of some other challenges. You can do a stage approach to endovascular treatment for them. You can stage it, you can do, and then you can repeat after.
Yeah, so just to add to what General has said, General has covered. You can see he's answered like a professor, so it's all good. So I think one way, and you actually have answered the question already in your presentation. One way is a lot of endovascular techniques have evolved and have improved so much over the last couple of years. AVMs, we always struggle with randomized control trials. You talked about Aruba, which caused a lot of excitement because it was a randomized control trial. And what level of evidence do you need better than level 1 evidence? I always feel that when you're answering things neurosurgical, once you back yourself with evidence, it's always difficult to be challenged somewhat, you know. And if you look at over the years, when they were using MBCAs, there were problems with embolization. Okay. Now with better techniques, the truth is you actually get some curative results with some of them, but then you have to make sure you do an angiogram post. But then the issue is, when do you discharge them as well? Like, when do you say your care is over? So I think that's where the challenge is usually, because you want to have curative effect. How long do you wait? Will there be collateralization? You talked about angiogenesis, but I've definitely had patients who small, sizable, it's in an eloquent area. You look at it and you're like, surgery would not necessarily help. It's a motor strip or something like that. You give embolization, you monitor them 3, 4, 5 years, and there's good curative effect. So I definitely think that now with better techniques, we're getting more curative effects. A few comments I was going to add. Grading classifications, I also tend to use the supplementary Lawton-Young nowadays. It's becoming really helpful, and it helps, especially when you're looking at the compactness or diffuse, apart from age. It's funny that surgeons will always try to simplify AVMs. There was Spätzler-Martin, I think that was 1986. There was actually one that you didn't talk about, Spätzler-Pons, which is like a simplified way of Spätzler-Martin. So you just try to break it into 3, like small, medium, and the big ones. So there was Spätzler-Pons, I think it was also in Barrow, and then Lawton-Young now modified it and added all those new ones to it. And the Aruba trial, it's a paper from 2014, and I think it's good for all of us to read the paper, because even though it's been totally rejected well, I won't say totally, but interventionalists and neurosurgeons did not really like the results of the paper. And there were different points. The reasons are because initially they aimed for a sample size of 800, but they actually stopped at, I think it was 223 or 233, because it was obvious that with patients who were having intervention, and intervention was surgery, embolization, or radiosurgery, was they were reporting 3 times morbidity mortality versus patients who had no intervention. 3 times. So they had to stop after like 230 patients. So they only got to a little bit over 25%, But what the Aruba thing did is it kind of made a lot of us become very conservative, where we were like, maybe these patients do not need treatment. Now, people have argued that the selection might have been biased. Only about, I think, 18% was surgical. So it's a bit unfair to say, you're comparing 18% and using it to say it's not helpful. And then one of the things that was the biggest bugbears was they only monitored the patients for 33 months, which in my books is really short. You can't really monitor AVMs for just 33 months and say you're having proper outcomes or definitive outcomes. 33 months, I think, is too is too short. Yeah, I think that was all I wanted to say, is anyway, regarding Aruba. And then you talked about genetics. So usually genetics contributes to about 5% of AVMs, from what they say. And the problem is there's so many genetic combinations. They're like over 900. So at the moment, we're still trying to understand the sporadic one. So it's a bit difficult to go for the genetic ones that make up a small limit. But if you look at the scans, you'll find out that just like strokes, AVMs tend to occur at watershed territories. And which, Dr. Kafo is here to, corroborate based on his findings, what he's seen. They tend to occur at watershed territory. So you look at the scan, and sometimes even when you see a CT scan, you're kind of convinced there's probably an AVM on the line, just based on the location, if it's on a watershed kind of territory. And people have said, fetal development, hypoxia, all those things might be contributory factors, just like you said. But the teaching has changed, unlike before, where everybody thought it's congenital. We're not really sure anymore. That's the truth. We're not really sure whether there's some that develop over time, or whether it's all an embryological thing. I've spoken to very senior interventional radiologists, and they tell you that, it's difficult for a fetus to have survived with, that AVM at that stage based on embryological development. So I think the teaching is shifting from it being wholly congenital. When we're describing AVMs, and there was a slide, I don't know whether you can put the slides up, when you talked about pathogenesis, you talked about the things that are seen on AVMs, feeders, the draining veins. I was involved in some discussion some months ago where they were talking about sometimes we have to look at other things as well, like venous congestion, like venous stenosis, venous dilatation. Those things help to say venous reflux, and sometimes nidal aneurysms. And in fact, in my unit now, what we do, we have a very experienced interventional radiologist. What we do is when a patient comes in with an AVM, we actually just go and glue, or rather the interventional team, they would glue the nidal aneurysm, the one that has bled, and then wait. So we'll wait and then now repeat a DSA later. By the time we repeat the DSA, of course, if the patient is low GCS, that's just straight to surgery. Then I'll go and maybe take it out myself or the other vascular surgeons. But if the patient is holding their own, we only just glue the nidal aneurysm that has bled, and then we wait for the clot to resolve, and then we repeat the DSA. And by that time, sometimes the AVM would have even opened up, because mass effect of the blood also sometimes give you a deceptive picture. And then we wait, it opens up, and then we decide on definitive treatment at that point, only if the patient is fine. And so that we'll wait longer than 6 weeks, usually. You talked about increase in bleeding. So 1 to 4% per year. The interesting thing is that it's lifetime cumulative. So if you see a 24-year-old with a bleed, of course, that's more dangerous than someone who's 70 years old, because you're calculating the 1 to 4 for the assumption is that everybody's going to live to 100 years. So it's done in a cumulative way where your bleeding risk is calculated on a 1 to 4% basis so if you're 24, that means 76%, and 76 years, 1 to 4. Do you understand what I mean? So younger patients usually would cause a lot of apprehension, where you want to try and make sure you offer some kind of curative treatment for them. And we know that if they bled, the risk is really high in the next 5 years after the bleed. So after the bleed, and you hinted at something like that on one of your slides, that the risk is higher in, I think, the first year, but usually the first 5 years. Now, there's something known as, depending on where it's located, there's something known as cerebral proliferative angiopathy, CPA. I've seen it once in the cerebellar hemisphere. And the reason why I mention it is because when this patient was referred to me and I saw the scan, I was already like, oh my God, I have to, what's happening? He hadn't bled. I think he was dizzy. I was like, oh my God, what am I going to do now? Posterior fossa, how am I going to tackle this? But by the time he had a DSA, it wasn't an AVM. So it looks like an AVM, even on an MRI scan, on a CT scan. But the major differences are there's no shunting. There are multiple feeders. Rather than AVMs, you tend to have one dominant feeder. But this one, there were multiple feeders. And then the major difference is there's the absence of early venous drainage. So, and it's interspersed into brain tissue. So if you do not know, you do an angiogram and you're like, oh, this is an AVM, let me just insert glue. Basically, you will just stroke out the patient. So that's why we also have to know how to interpret angiograms and interpret AVMs, because cerebral or cerebellar proliferative angiopathy, they look like AVMs, but they are actually not AVMs. Of course, the thing is, when I'm explaining to patients, I always tell them it's like water pipes, that the water pipes are coming from the headquarters and comes to the town, comes to the village, comes to your house, and then to the kitchen. So I always say that the pipes get smaller, and that's normal. That's how it's normally, usually. But that with AVMs, sometimes what happens is the contract was given to the wrong company. Maybe the Senate gave the wrong person, and then they just transferred two big pipes all the way to your bathroom or to your kitchen. And of course, when you have the pipe coming from the water corporation directly, it means that your house will probably flood. And then maybe Dr. Kafo's house will not have water because my house has water, to explain this still. And when I explain that to patients, they always laugh, but they always understand what AVMs mean. It's a simplistic way of explaining it, but that's kind of the way I explain it. And then the final thing is SRS, you talked about the latency period. So usually you remember that if a patient comes in with a bled AVM, even if you wait and you refer them for SRS, it means that until the 18 months or 2 years after the SRS, they are still vulnerable to a bleed. So you always have to tell them that. So it's usually safer if they've not bled. If they've bled, then that's a problem, because that risk period, they are still open to it. So SRS for ruptured AVMs, even if they're GCS 15, is always a bit risky. And then the other thing I've seen with SRS is all well and good, fancy, gamma knife, whatever. But sometimes it's less than 5%, but you can have refractory edema from SRS. And I've seen, I think, 2 cases now that were really bad. Most people tend to treat them with steroids, dexamethasone, but even that does not really work sometimes. So some places would give Avastin, which is pefaxisumab. I don't know, Uche, if you've seen cases like that, but I had to apply privately for one patient to get it because he had, and he was a young guy. AVM was on the motor strip, large AVM, and they planned to give him 4 courses of SRS. And then after the 2 courses, there was the edema was so bad that he just literally had a stroke from the SRS. So they referred him and they just dumped him under me and said, we can't do anything. They stopped the treatment. So I was giving him steroids, but every time I weaned him off, he would just go back and start the steroids again. Whenever I'm not on call, he comes in A&E, someone will start him on highest dose of dexamethasone again. He became cushingoid. So I started going through the literature and I found out that Avastin could help. The evidence is not great, but I've seen patients from Asia, Bangladesh and India. I saw a patient from Apollo in India who they start them on it immediately. after SRS. So I applied for it for this patient, and it really helped. So SRS is not risk-free. We all have to know that, you know, there's a lot of risk with it. And then this parallel microcatheter method, I think it's the one that our interventional uses. He calls it pressure cooker, where he puts two catheters and tries to remove one. And that's so that you can just block the part you want to block. But I guess Uche will probably explain that a lot more, because that's more his territory. But yeah, those are all my comments. Thank you very much, Jeneral.
Thank you, sir.
So any other comments? We've got Prof. Bankole here as well. Michael Adeboye, I'm not sure, I don't think I've met who that is, but yeah.
Well, good evening, everyone. Well done, just listening in. Yeah, interesting, nice presentation, General. The part I caught, I think I came a bit late, but yeah, and thanks for the comments. Well, we mainly just do open for now, with some success, but very careful patient selection. That's what I'll say about that. All right, let me allow other people to talk.
Thanks, Prof.
Michael, do you want to introduce yourself? I don't know, Michael. Do we know him?
Michael Adeboye.
Yes, sir. Good evening, sirs.
Hello, hi, Michael.
I'm very good.
Are you based in Lagos as well?
No, in Ilorin, actually.
Oh, okay, okay.
Yeah, I'm coordinator of Young Nigerian Neurosurgery Forum, and at a point in time, we brought you on for aneurysm, subarachnoid
Oh,
hemorrhage,
yes, I remember you now. Sorry, my bad. Yeah, I remember you. Yeah.
Thank you
Nice
very
to
much.
meet you.
I just want to say I've really benefited from the discussion so far. So we are still babes coming up. So just here to listen and have some weight of experience. Thank you very much. Thank you very much, Dr. Jeneral. Thank you.
Thank you so much. I appreciate it.
Michael, thank you very much for joining us.
Yeah.
I know it's late.
Oh, Kingsley.
Kingsley has a
wants
question.
to
Go
ask
ahead,
a question. Yeah. Kingsley, yeah, the floor is yours.
Okay, good evening, sirs. Thank you very much for the presentation. I really gained a lot. There are two parts. The first, there was a place you said something about it being common, 40-something%. So I'm not, and then I know eventually you said something about it being rare. So I think that I misunderstood what we were alluding to within the earlier slides. You said something about 40-something% of, I not really get what you were talking of in that place. Then secondly, in our environment, before a patient will do a CT scan or an MRI in the first place, considering everything is coming out of pocket, patient will be symptomatic, and these symptoms will probably be headache that is very severe, or more commonly maybe seizure, focal neurological deficit. And then before the person we even talk of doing any other the higher imaging, angiogram, and so on. So in such a case, I'm wondering if we now have the room to consider this. We've been talking about how AVMs may benefit, should. Now, we don't always rush to intervene. But in our environment, that's, even doing the first CTs is something that somebody has to think about so long. Because if you are not going to intervene, that means you will need to be regularly doing imaging for these patients and so on. So I want to know how we could color that recommendation, considering the particular our own environment and so on. What we do for now is open surgeries, and I know I've seen a number of the open surgeries. So I don't know how we could look at it from that angle with regards to our environment. Thank you.
Jeneral, do you want to answer the 40% question first, and then we can talk about the other one?
Okay, yes. The The 40%, it's the talking about AVM with respect to intravascular malformation. So when you look at intracranial, intracranial vascular malformation, you know, I said McCormick classified them into 4 large groups. So the AVMs, the venous anomaly, the cavernous malformation, the telangiectasia. So AVM is the one that accounts for 44 to 60% of intracranial vascular malformation. That was what I said in the first slide. But in the epidemiology, what I was given is the dictation rate and the incidence of AVM in the brain, not in terms of vascular malformation. So it's the commonest form of intracranial vascular malformation, but the incidence of occurrence is what I said, about 0.2 to 0.8%.
So
Thank
Kingsley,
you.
did you get
That
that
is
bit?
clear.
Yeah.
Yes,
Yeah, and I think your other question about timings is a really tricky one, of course, because that means that I would say that for me to open someone's head without an angiogram now, it most probably would be an emergency case. An emergency case that comes in, bleeds, maybe the middle of night or out of hours, low GCS. That's the one that I would say, yes, I would evacuate the clots, evacuate the AVM. Of course, I always dread if it's posterior fossa. We all know how posterior fossa, how challenging posterior fossa cases are. Nobody's happy for an AVM, but I usually go in kind of, you know, sometimes I'll put clips on pica once I open up. I'm just like putting clips on the arteries, just, you know, to be very careful for control. The good thing is that a lot of, well, I won't say a lot, but sometimes you'd also see the patients who are not low GCS, And I think those are the ones that, in terms of delayed scanning, it might not necessarily have too much of an impact on them. But based on the, you know, our attitudes and how many of our patients are, I'm thinking that, especially from what you said and from what Professor Bankole said and what Jeneral said as well, is that maybe our patients might not necessarily present until it's too late, most of our patients, because even if you have a mild headache or you have some seizure, you're still staying, you know, probably staying at home. I don't know, but that's what I'm guessing. But the delayed scanning would pretty much be useful in the patients who they are good, they don't necessarily deteriorate on time. And the truth is, when you do a delayed microsurgical resection, it's actually much better than an acute one. Definitely much better, because there is now area of gliosis around it. So it's actually quite, well, if you see a good one that is maybe frontal lobe and all of that, it's actually kind of enjoyable if you're able to pick up the blood vessels, compared to when you go in and do acute one where you are, you know, using holy water and you're praying to Baba God in heaven, you know, that kind of one. But I must say that most cases, if I can get, and that's why for me, the work of this initiative is very important, because most cases, for as long as I can even get some embolic material in the nidal aneurysm, I will try to get that as much as possible. And I hold my hands up. I'm not going to say I'm heroic or whatever. If I can speak to, you know, the interventionalists, we get a DSA, and we identify the point of the bleeding. They put some embolic material, and it's the same anesthesia. Immediately after, they just ship the patient straight to theater, and then I take out the AVM. Yeah, and it definitely changes the whole setup, which is a privilege that we don't have yet, you know. And that's the big issue.
Yeah, I quite agree with you. It's quite challenging here because imaging does a lot. it gives you a kind of an idea before going in. You're able to know where even vessels to avoid, vessels to approach, and how to even approach it. But in the absence of imaging, it can be quite challenging.
Yeah.
Quite challenging.
It can be because routine, I must say for an AV, and that's why I said acute ones you do at night, and sometimes you hate yourself that, oh, why can't you get a DSA? So I think over here we've been spoiled to the extent where there is always a DSA unless it is at night. So if you can try and move the patient to during the day where you can have a DSA to plan and to do everything, then you would do that, or even a CTA at best.
Yeah.
Is that okay?
Another thing to also emphasize is to bring out is that's conservative. One of the treatments was supposed to be conservative.
Yeah.
How applicable, how practical is conservative measure in our environment?
Yeah, the truth is, we in our environment, and now I'm aligning with you in terms of in our environment, we are not necessarily going to see incidental AVMs. So that already rules out. So there's so many people walking on the streets of Lagos who have AVMs, but they don't know because they've not been scanned. In other countries, when they sneeze, they get a scan. When they cough, they get a scan. So we're seeing a lot of very small AVMs on maybe motor strip, large AVMs. Some AVMs, even Spencer Martin, they go 6, where it's the whole hemisphere, and nobody would touch them. The large hemispheric AVMs, nobody touches those. They just leave them. They'll be following them up. But the day you bleed and you meet your maker. So there are some AVMs like that. Nobody will touch it. So, so if we see those, but the thing is, I think in Nigeria, we will mostly see AVMs that are large and are bled where there's a presentation. I don't know if Professor Bankole wants to, correct and give an opinion. Professor Bankole, what's the demographics of presentation patterns for AVMs? Are they typically large and the ones that have bled, I'm presuming? Is Professor Bankole still there, or is gone? Or maybe not.
He's still online.
Yeah, but that's what I would think. The ones you've seen, Kingsley, have they been large and are bled?
Yes, they've mostly bled. They mostly bled.
Yeah. So typically, but the truth is, we would see ones that have not bled. Uche, what about you?
Yeah, so people present with a seizure, they get a scan, CTA, they get an angio, we pick it up. So we kind of pick up, like you said, the ones that are smaller. Those are just coming with a hemorrhage, to be honest.
Yeah. Or headaches.
Yes,
or
headaches, exactly.
Yeah, I had
some screening.
Yeah, 3 weeks ago, I had someone it was in the gym. He was lifting some weights in the gym and he had a really bad headache, presented to hospital, ICH, and there was an AVM under it. Yeah, so ones like that. So I think it all varies. And what Jeneral has highlighted is, to be honest, the reason why we can have as many classifications or grading systems, AVMs, they're so different, isn't it? Patient type, the feeders, location. So it's very difficult to kind of fit them all into boxes, which is what we are trying to do. Just make it simple so that we can deal with it. But the truth is, there's so much heterogeneity, too much variability with AVMs that we really have to sit down and say, what do we think is the best? If it's on the motor strip, for example, I honestly think opening someone's brain and feeding with the motor strip, no matter. Oh, Professor Bankole is off now. Okay, yeah. Do you want to say something, Professor Bankole?
Oh no, sorry, I stepped away for a moment. Did you ask a comment?
No, we were talking about typical kind of presentation partners or patterns of AVMs in Nigeria. Like what kind of cases? They're typically large and are bled, isn't it?
Yes, yes. So typically large have bled, probably sometimes more than once. At least in the past, when they did that, we just said we can't do anything, go away. But now we've taken on a few that have bled, and then one or two that have had seizures.
Yeah, and usually the GCS, typically for most of them, good or bad?
Well, the ones we have done have been good because we sort of waited for them to survive the acute phase and then went on to do the definitive surgery a few months later.
Okay, thank you. Yeah, so like we thought. So I think let's be wary of time. Yeah, so that we wrap up. I think Jeneral gave a really brilliant presentation. I loved it. Hope you can be presenting, every other week after our switch.
Yes.
This is a borrowed experience that I'm using.
No, Jeneral, you did a great job. You raised the bar. Thank you very much. John, Michael, who else joined us again? Please feel free. George, please, can you add them to, if you're interested, George will add you to our WhatsApp group.
They're in the WhatsApp group.
Oh, they're already in the group. Okay, awesome. So we do a lot of, we meet every week here and lots of learning going on. Apart from Grand Round, where we're developing ourselves. That's what this is about. So thank you so much. Alalade, thank you. You knocked it out of the park. We are better for it today, no doubt about it. Just a few comments and then we'll go. Let's remember the M passage vessels. So that's the one that, that's why imaging is important. DSA will help you with your surgery. You go and knock out a vessel, supply normal cortical, territory, and you give them a stroke. And you think it's a feeder. It's not a feeder, it's going past the AVM. So be wary of them when you're doing surgery. And then for the pressure cooker technique, so in summary, just to make it easy, what actually happens is, if you use Onyx, for example, Onyx 34 is denser than 18. 18 is the commonest Onyx we use, embolic material. But Onyx 34 is very thick. So what you would do, you put two microcatheters, you use a intermediate catheter, maybe an 071, an 068, Sophia or something, that can take two microcatheters. Microcatheters are like maybe 021, 034 in diameter. So you can actually put two microcatheters in an intermediate catheter. And then one will be proximal, one will be distal. The thing we fear is retrograde embolization. You don't want it to go back because it will go back and block normal supply to other areas. So you deposit your 34 proximally in very close to the AVM, to the nidus. Then you wait, you sit, you wait, it solidifies. Then the distal catheter, you begin to inject your 18, which goes more distal. Some people will use coils to slow down the flow, and then while they put the coil, and we're going to do it. We're coming. Lalade, we're going to Nigeria next week. Myself and Misha are going down. Misha is a pediatric radiologist and interventionist, so she has a lot of experience with this. We have a vein of Galen malformation. We're going to deposit coils and then we inject glue inside of it, so it just slows things down. So that's really the pressure cooker, technique they're describing to make it safer for embolization. Otherwise, your stuff will just go and will dispel antegrade or even go retrograde. And you can't do anything. You just watch it. It just keeps coming back. You're like, what do I do? Or you use a balloon guide catheter. So you use like a Septa C, Septa Mini catheter that proximally will, so before you start injecting, you inflate the balloon, and the same catheter has, it's dual lumen. So proximally the balloon and distally there's outlets. So you can inject through that. So whatever is coming back will stop and start going forward into the nidus. And that's what you want to happen. So that's really what that technique describes. So I don't want to just, because we can keep on with this. So I'll stop here, and Pathology, maybe you help us close out. Thank you.
Yep. So thank you very much. We'll meet again. Actually, next week is the workshop, isn't it, in Niger? So
Yeah, it's going to be live. So
we'll be
everybody,
meeting
please
again
come
in
on.
2 weeks. Yeah. So everybody to attend that. Where is the location? Have you told everybody?
It's in Lagoon.
Lagoon.
So please do register. There's a registration link. Prof, I don't know if you want to, there's like as many people who can join, or maybe the residents and those who, even radiology people that want to learn new intervention, radiology or neurology, we're open. We're not, we'll allow them to learn. Don't worry. Like you British
Yeah, I
people
think
that don't want to
put it
teach
out
us.
on we put it out on some platforms. So yeah,
Yes,
I think we'll get people coming, at least for the workshop aspect.
For the workshop. So it's going to be Sunday, next week,
Sunday afternoon. Yep.
Sunday afternoon, 12 o'clock. So there'll be a practical session. Misha is full of stuff. She says she loves teaching. I said, bring it on.
That's great. That's good.
So she's really looking forward to discharging by God's grace and helping. All right.
So that'll be Lagoon, Victoria Island, just for those. But I guess anybody that registers will get more information.
Okay. Good. So hopefully everybody attends, and then we'll meet again the week after that to continue.